insightful comments. Can we move on to Andreas Hoeft? And now that we've established you're from Bonn, do you see any differences between failure to rescue in Europe versus the U.S., Andreas?
Well, should I say no and yes, or yes and no? Well, first of all, Europe is very diverse, much more diverse than the US, and we have some low resources countries which have, let's say, other healthcare problems or additional healthcare problems. On the other hand, I think there is no difference, let's say, in the normal resources or richer countries. Pretty much the same, and we just did that surgical outcome study, which was published in Lancet last year, with Robert Pierce as the first author, and we saw that we have a much higher mortality. The stunning observation was that much more patients die on the normal ward and not on the ICU or in intermediate care. 85% of the patients, regardless whether in the low or high resource countries, die on the normal ward. I would have expected that deadly sick patients would be on an ICU, but they are not there. So this clearly indicates the magnitude of failure to rescue. We had a mortality rate in that study of close to 3% in average all over Europe of surgical patients. We do have, for instance, in Germany, 12 million surgeries a year. So that mortality rate means something like 400 to 500,000 patients per year. 85% of them die on the normal ward. And this is not all metastatic cancer. And my gut feeling is half of those are failure to rescue. So we are talking about 250,000, 300,000 patients in Germany alone, which are possibly failure to rescue.
I'm intrigued by the observation that complications among hospitals often are very similar, but in fact the outcomes are better in those hospitals who rescue more frequently, who are more adaptive.
That's a paper by Gaffery in New England Journal who has demonstrated it perfectly. And that is why I think that we can really make a difference in that area. There is something to win for the patient. And I disagree with Joe. It does not need to take 7 years, 5 at maximum.
Now let me ask you, Andreas, could an argument be made that all patients in the hospital should be monitored? Isn't it true that some deaths are in patients who would not be deemed to be at risk?
Yeah, well, I think it would be ideal if every patient would be monitored, but I think that there are clearly risk groups or patients at risk which should be monitored preferentially and as soon as possible. The question is, I believe if we would be a little bit more modest and say we identify clearly the patients at risk, which would be all patients with opioid therapy or PCA, of course, and there are other risk factors, I guess that we can identify preoperatively, so that my estimate would be 20 to 30% of, and I'm looking on surgical patients now because that is my area of expertise, being an anesthesiologist, 20 to 30% might need monitoring. But with those, I guess I would believe we can save 95% of preventable deaths.
Do you agree that all patients receiving PCA opioids postoperatively should receive monitoring?
Actually, this is policy in my hospital, but of course.
Let me ask you, I guess, a related question. How should we consider cost in addressing these known and addressable patient safety issues?
Let me be provocative.
Can we print a platinum coin and solve it all?
No, let me be provocative. We shouldn't consider cost at all. No, more seriously. Yeah, Joe, I understand that you applaud, but no, more seriously, it boils down to an ethical and finally to a political or social political question. How many resources is a society willing to spend on health care? So, of course, give you an example. It would be ideal we would put a nurse next to each patient to the bed. Nobody can pay that. We might have more intensive care and intermediate or IMC, intermediate care beds, we can't pay the person now. So there needs to be a technological solution, I believe, for patient safety in the future. And costs should be secondary. I'm not saying costs are irrelevant. Okay, we should choose a cost-efficient technology to save the patients. But at the end, it's an ethical and a political question.
I think it is a dilemma to deal with what seem to be obvious safety solutions and whether you should have to deal with the cost implications. And I think I've come around to really feeling that with respect to opioid-induced ventilatory impairment, monitoring the cost is not an issue.
Well, cost and cost efficiency is a very difficult topic, and the answer is different, in particular in Europe, between countries. It very strongly depends on your reimbursement system. To be a little bit cynical, the most cost-efficient way would be what we call in Germany sozialverträgliches Frühableben. I translate that. That is socially compatible early death.
Oh.
That is most cost efficient, isn't it? But of course, can't be the solution. So I'm a little bit, let's say, reluctant to discuss costs at all. We have other goals, don't we?
Yes, thank you. Michael Ramsey, can we move on to you?
Yes, Bob.
Michael, would monitoring mandates as so-called official hospital policy be more effective, you think, than individual physicians or groups